cancer that you can actually improve upon if you treat patients with Barrett's with low-grade dysplasia. So that is actually different from like 3 years ago. In our list of treatments with of possible ablative therapies, you know, about RFA and all the evidence that's accompanying that from the past 10 years. I want to update you on that from the science in this meeting. And also there's spray cryotherapy, which I'll go over. There's also new evidence from this group for something called hybrid APC, which I don't know if you've heard about it, but essentially it's your APC generator that you have in your units that has a special water jet attachment and a special catheter that allows you to both inject and raise. I'm going to show you that in a minute. So again, these technologies have developed just in the past 5 years, so this is something for you to learn about. Now, RFA, as you know, had this randomized trial which changed practice. It really allowed us to treat patients to complete eradication of their Barrett's esophagus as well as their dysplasia. And this meta-analysis and scientific review I showed you here basically shows that eradication of dysplasia, complete response to dysplasia or eradication was 91%, this is in 11 studies, and 78% for complete eradication of intestinal metaplasia. So this is the current standard of care, right? Now what is new in Barrett's RFA treatment is this new sizing balloon catheter system. How many of you are using this already, the Halo 360 Express? So as you know, there was some controversy, even with the standard circumferential balloon, about what dose to do. Initially, from the New England Journal paper, the AIM Dysplasia 2 trial, it was ablate, clean, ablate, right? And then there was another Dutch trial that said ablate, no clean. And it actually had comparable results. So this takes off one step from the RFA process by really remarkably removing the step that makes you measure the diameter or the balloon diameter that you need to use in your patient. Some people have really big esophagus and they take a 36 millimeter balloon. Some people have a very small esophagus, and that's why sometimes there was some pairing with Halo 360s in the past. So this is the just to go over the technique with you. Here's the long Barrett's esophagus, C6 and 7, multifocal low-grade dysplasia. There's a hernia, and you don't need to really do the measurements anymore. We should pass the guide wire to then pass a different sizing balloon, if you will, to get the diameter. So the steps are the same in that you pass the Savior guide wire, you then pass the Halo 360 Express catheter over the guide wire, and then you pass your scope side by side to the catheter. You pull back just where you can actually just be proximal to where the balloon, proximal level of the balloon electrodes are. And here you are, you're going to actually treat from proximal to distal. And you see the Z line right there, you line it up where the electrodes are. So these are the electrodes. These are circumferential electrodes that go about 4 centimeters long across the length of the Halo 360 balloon. And what you want to do is at least line up the proximal edge of your Barrett so that you have about a centimeter approximately of proximal length of the electrodes beyond that. Now you step on the pedal and you inflate the balloon, and you actually, one mistake or one improvement point is that some people ablate right away. You need to really wait to see it through the balloon by putting your scope on the balloon, that you've actually flattened all the folds before you have to step on the pedal. So one problem with actually not completely ablating the Barretts is to press on the pedal too soon. So now that you've done the ablation, you then do a cleaning step, which is a cap on the scope. So this is the most tedious part with long Barretts. You just clean all the coagulum off. And then finally, after you've done that, you actually then go back down and repeat that step with the same technique of ablating from proximal to distal, depending on the length. And so this dose regimen, which is the 1 clean 1, meaning 1 hit of 10 joules clean and then another 10 joules, is what is in the multi-center trial out of Europe, which they were trying to randomize to see which would be the best, most effective technique. And in fact, this is the results from their abstract, where they tried to compare simple double, which is 2 of the 10s hit with no clean, versus 1 clean 1, which is the standard, versus just 1 with no clean. And the big message for you to remember, for those of you who are doing RFA, and they actually sent this out, a letter to the editor of Gastro, that there is such a high stricture rate with the simple double arm It's about, I think, 21% or so that you actually need to stop this part of the trial and actually don't even consider doing this dose regimen at all. So this leads to a high stricture rate. Okay? Now, moving on to hybrid APC, again, the big advance in technology about this is that it combines 2 steps in one. So you don't need to take out your sclerotherapy catheter and then inject saline or whatever and then lift up the mucosa to separate it. In this special hybrid APC catheter, you actually have needleless injection. So there's a pressure of saline coming in from the water jet component of your Irby device. Typically, some people mark, but the injection of the saline is at a certain pressure. So the pressure is actually high, but the volume is low. And in fact, when you do this, I hope you can visit, in the booth if you want to see it live. But you actually step on the pedal, and you can, with each beat, it's about a cc of saline. So you actually kind of know without the nurse shouting to you how much volume there is. So you step on the pedal, and 1 cc, 2 cc. And at the same time, like you do with EMR in the colon, you're actually seeing the lift of the Barrett's, separating it from the submucosa. You can also do this in increments. So the idea would be to inject to lift, and then you would then burn with actually much higher dose of energy that you normally would use, for example, for AVMs or something. So it's about 60 watts with a pulse effect of 2. So you're burning, you'll see this charring, right? And then after that, you scrape with the coagulant. It's the same kind of like an RFA, where you scrape off the coagulated tissue to then expose the underlying deep mucosa that may not have been reached. And then you then go down. This is an important part for safety, that you go down on the dose to about 40, and then you burn. And the end point is it's the same kind of principle as the RFA, where you look for this. In RFA, you look for the chamois colored change, right, after your second hit. With this, you look for kind of like they call it a toasted marshmallow appearance. So if you don't toast marshmallows, how would you know? But it looks like a toasted marshmallow. It's kind of like grayish yellow, and that's the end point for doing hybrid APC. There is a randomized trial that was presented in part this morning at the HD plenary, just preliminary results. And there's one German study, which is this one by Hendrik Nanner in endoscopy, which actually showed in 9 centers, actually almost all of them got EMR as part of their treatment, that they had 92% crim rate, which is really astounding. In fact, they actually had, some of them had really long Barrett's, most of them had shorter lengths of Barrett's after EMR, and there was a reasonable rate of restriction of about 4.8%, which is comparable with RFA, right? So again, just in principle, I don't have this video to show you, but you just put the water jet catheter, hybrid APC catheter, on the mucosa as perpendicular as you can, and then you step on the pedal and it raises it. It's actually quite nice. So here's just a little video of the appearance with the cap. You're going to do this with the cap on, and you're going to then, after you burn, after you raise it up, I just want to show you the kind of the end point thing. So this is not enough. You have to burn some more, and this is what essentially, move it forward for me. So the end point of this treatment is to make it kind of yellow toasted marshmallow. All right. So now I want to talk about now cryotherapy. I've been doing cryotherapy for almost 15 years, and the one that was invented at Hopkins by my colleagues was CO2 cryotherapy, and it actually it's a very nice principle. It's carbon dioxide compressed gas in a tank. And then basically, when you release the pressure, you release the CO2 with a foot pedal, you open the valve. That change in pressure causes freezing. So you're not spraying liquid nitrogen, it's just the Joule-Thomson principle. And in fact, it actually worked really well. The initial application of the Polar 1 device was in treating refractory GI bleeding. And in fact, it works in refractory GI bleeding. In fact, we still use it for that indication. But I used it in Barrett's, and we actually showed it actually did a decent job of ablating Barrett's, including dysplasia. This is not so more used in our unit just because of the frequent need for cycling, freeze-thaw cycling, and it was sort of unpredictable how much cryogen or how much freezing you actually got on the mucosa, and that's why the crim rate was about only 65%, so not as acceptable. There is the liquid nitrogen type of cryotherapy, which is now actually liquid nitrogen in a tank, which is passed through a heated catheter, and typically you do this with a cap so you can actually focus the liquid nitrogen on the mucosa. And they have a dose regimen that's about 20 seconds. They treat hemicircumferentially, and then you thaw for a certain number of counted seconds, and then you do it again. So there's been some change in the dosimetry, but again, the principle behind cryotherapy is to freeze to a certain degree to get the temperatures down below -40, and that's studies that have really shown good efficacy. So today I also want to introduce to you in principle relatively new technology called cryoballoon ablation. It's something I've been working with for the past 4 or 5 years. It's something you may not have heard about. Anyone hear about this already? Okay, good. So some people hear about that. So what's interesting about this, and I actually tell a story that I met the founders of C2 Therapeutics, who are now part of Pentax, in a DDW in San Diego before, is they carried this around in a little suitcase. So well, I've never seen an ablation therapy that can be carried around in a suitcase. And in fact, it was very intriguing to me that you could actually design this ablative therapy where you actually have a liquid nitrous oxide capsule, a small capsule, in this battery-powered handle, which is totally electricity-free, which is battery-powered. And this is portable, so you basically have a handle where you actually control the release of the nitrous. It's attached to this cryoballoon, and this is the cryoballoon. And within this balloon, there is an aperture, which is called a diffuser, where when you activate the handle, it will actually release nitrous oxide, typically in liquid form, it expands to gas. And with that release, it will inflate the balloon, and you'll be able to then make contact with the walls of the esophagus, and be able to see through the balloon to ablate the mucosa. So the simple thing that attracted me about it was that it's very, very simple. It's only one, kind of like point and shoot. You don't have to count seconds, you don't have to thaw, you don't have to debride and scrape and freeze thaw. So for me, that was very important. There was consistent dosing. I know that every time I freeze, it's 10 seconds of ice to a certain temperature, whereas when you're spraying around, you don't really know how much of the mucosa is frozen uniformly. Most importantly for my nurses, they really love not having to change tanks. Tank changing is a problem when you have cryotherapy that's released from a big tank. And certainly gas venting, which is putting the entry tube down like it would be with liquid nitrous cryotherapy to vent the excess nitrogen gas is important. And then certainly also important for endoscopy units is that there's really, with this current generation, no capital expense. You don't have to go to your VAT committee, you don't have to apply for so much capital. This is disposables, and the disposables can sit in your shelf and you use them and use them as you go. So this is just a video of one of my patients with Barrett's dysplasia. You see I've already frozen. This is the focal balloon where you actually have a focal freezing. This is the view through the balloon. So we routinely use high definition endoscopy so you can see the Barrett's that you're treating. I've already done about 2 ablations, and you can see the way you can actually rotate with the handle. You can rotate the direction of the diffuser, and so now I'm treating at 12 o'clock. And you can see with the 10-second dose, you can easily freeze. You can see what you're treating. There's no fogging of your lens. There's no mist and all that. And you can see you can treat specifically target areas. You can spare the squamous mucosa that's normal, which you don't when you do a circumferential treatment. And so all this can be done in about averaging 9-12 minutes is what we're doing now for even long lens Barrett's, because it's pretty efficient. So again, something that was very intriguing. We also then look for this cryoballoon treatment effect, which is the red color change. We see that with any cryotherapy. What happens with cryotherapy is that there's immediate and delayed effects. The immediate effects are freezing, cells burst, thrombosis of small blood vessels, decreased blood flow, and the delayed effects then include apoptosis and cytokine mediation. But it's sort of a more gradual injury and death from the cells compared to, for example, coagulation with RFA or ATC, where the cells die immediately because they're burned, right? It's really high energy. So you see this type of red color change typically very, very focal. It almost exactly replicates when you're treated. So the nice thing about it is that you know where you're treated. There's no doubling up on where you're treated. You can actually then make a very confluent, seamless treatment, even if it's a focal device. You can actually adjust the dose up or down, and what we've done in the trial is to actually use the 10-second dose that has been shown in the first single-center, multi-center trial, which shows that actually the injury of the effect of the cryo is mucosal for sure, necrosis, but the injury when you do the pig and other kinds of lab benchtop models actually reaches the submucosa, but the submucosal components are spared. So basically there is no, when after the injury there's recovery and there's very little after effects in terms of the benchtop dosimetry studies. It clearly is a deeper injury than RFA. It definitely traverses the entire length of, with the depth of the mucosa, which has been a problem sometimes with thick Barrett's esophagus, right? That basically you have to keep burning and then scrape and burn. And sometimes with mild mucosal irregularities in Barrett's, as you see, not all Barrett's is perfectly flat. This might be some advantage over RFA. Again, we look for this red color effect. We look for skip errors like this. I don't know if you can see it, but it's a small error that does not have a red color change. We would treat that and go after it with a 5-second dose of Triogen. And this is the results of our single-center Johns Hopkins prospective clinical trial that basically treated Barrett's patients who either were never treated with ablation or who actually previously treated with ablation and failed, right? And the failure defined as previous RFA with persistent dysplasia, stricture, or more than 3 ablation sessions. And as you can see, this was just published like 2 weeks ago, so please go check it out. But the 95% complete response to dysplasia was astounding. But I actually was very, very pleasantly surprised it would be that good, even with just a focal device. And we treated patients with long Barrett's. About something like 25% of our patient population had more than 8 centimeters. And a CIM or CRIM rate of 88% is actually quite high compared to what there is out there. So 78% for RFA in the pooled analysis. So this is a really decent initial results for the first-time path of looking at how it treats Barrett's esophagus. So this is one of our patients. You can see this is a patient with high-grade dysplasia, no lesions, C3M4, obligastric folds. After 2 treatments, which he had no pain at all, absolutely, he had negative biopsies. And he's been a persistent responder for 3 years. So again, we have an abstract this meeting, I think it's tomorrow noon, where you can check out the durability, and we also have a pain abstract that's also reporting the preliminary results of our multi-center trial that's ongoing now on Barrett's dysplasia. This is another example of a C8M9 long Barrett's. What's interesting is you can see that even if you treat all this Barrett's the first time, that the Barrett's does not heal or regress uniformly. So you can see the neosquamous, after 1 treatment, you have 1 little island after a second treatment, and after 3 treatments, again, really long Barrett's. This is comparable to RFA, right? So the best thing about this, and this is partly why, we've done the studies and done the trials, is the patients have far less pain, almost no pain. It's also short-lived. Pain grade right after the procedure, median score is 1 out of 0 to 10. If they do have pain, it really resolves immediately by the next day. They can resume their diet. And then in this meeting as well, the Dutch group did a concurrent prospective study, it wasn't randomized, of measuring the pain and all the effects of RFA versus cryo balloon patients. And what was very nice is that the pain scores, sorry for this problem here, the pain scores were universally significantly higher in RFA patients and lasted longer, which is the red line here. And the need for narcotics for RFA was much greater compared to the patients who were treated with RFA, with cryo. So that was really significant. Patients with RFA also had dysphagia for much longer, whereas patients with cryo, as you can see here, had none. So part of the patient tolerability is also an important reason why you would offer this to the patient. It's something that is potentially as good, potentially safer, more tolerable, and this is where we need to go with kind of randomized non-inferiority trials that are planned. The other small side benefits of this treatment is that, remarkably, this is a patient who had high-grade dysplasia, had 1 RFA circumferential treatment, had a stricture but really miserable, had at least 3 dilations, didn't want any more RFA, and came to us, had residual Barrett's above and below and within the stricture, And so this is the view through the cryoballoon of the ice patch treating above the stricture, through the stricture, and just distal to the stricture. You can see the ice patch goes beyond where the narrowing is. And remarkably, the stricture doesn't get worse. It doesn't bust open. It doesn't get more narrow. The patients don't get dysphagia. And so this is a bit of an interesting area that potentially might be better treated, right, in patients with cryo versus other technologies. One last thing I can tell you potentially there's a salvage effect of cryo over RFA. So those were primary treatment patients. That these two studies are small, showed the liquid nitrogen cryo spray. 75% of patients may respond with terms of dysplasia eradication. In our study, we had half the patients who were actually previously treated and failed mostly RFA. But you can see the efficacy, which is the CRIM and CRD rate, was comparable to that of patients who had no prior treatment. So again, we actually have planned a multi-center trial that's going to evaluate this technology in patients with previously RFA patients who are resistant or have failed RFA treatment. Finally, cryotherapy can cure early cancers. This is an intramucosal cancer that could not be raised and treated with EMR in a kidney transplant patient with heart disease. She wasn't going to go to surgery. And here is the the cryoballoon treatment. You can see now the focal spray treating the mucosal cancer exactly where it is, and she's out 3 years later with no residual disease. This is the images from these other studies that are showing you benefit of cryo in cancer patients. Again, RFA can't touch this. We can actually dial up the freezing and increase the cryogen to treat these patients. There's about a 77% cure rate with cryo alone, with liquid nitrogen, and patients with mucosal cancers where EMR was not possible. So this is the new generation system that I think they're going to show you in the booths. I think Angela over there is Angela from C2 has a mock device that will be there. But essentially the improvement is that from that little handheld thing I showed you, there's Angela, there you go. It's attached now to a pedal. Whereas before, this handheld device was controlled by your assistant, your nurse or your tech. And often, part of our learning curve was, okay, turn here, do that, and it would be sort of uncoordinated sometimes. Now, the endoscopist has complete control over the aiming and firing of where you're going to fire. Additionally, the new generation cryoballoons can not only turn circumferentially, but also it can also move distal to proximal. So if you're at the G junction, you need to have something that is actually just above and treat below, and you treat in the junction as well, which is where we start. You can actually move the aperture of the diffuser and actually not move the balloon and just be in place. So it makes for a more efficient delivery of cryogen. It's actually easier and faster to learn on this than it would be with the actual original device where we did our study. So this is just a patient that we treated with a wide area cryoballoon ablation. This has not yet been officially released, I understand. When I showed you was focal. And what this gives us is the possibility of treating larger areas, circumferential Barrett's, which we want to do in this disease. And the difference is that now you have a whole length of catheter, about 3 centimeters long, in the balloon. And we are able to place this in the Barrett's. Let's move it forward. So what you see here is, again, the view through the balloon. And you can see this about 90-degree wedge of ice, and typically the treatment is from distal to proximal. So you're positioning the balloon in the distal esophagus. You step on the pedal to inflate it so you can see through the balloon. You don't need any mucomis, by the way. This is not dependent on dissolving mucus the way it would be with RFA. So step on the pedal, see the view, and then you can see that this is now diffuser, which started here, and it moves back this way to actually create this wedge. I think this video was not edited so well. Okay, so now we've done this treatment. We're doing this 12 o'clock section of the distal Barrett's. And you can see you can create a circumferential treatment with just this sort of focal wide area treatment. And certainly there are planned trials that will use this next generation device, which hopefully, stay tuned. So if we just summarize by comparing APC versus cryo versus RFA in terms of the data, you can see that they're all pretty good with eradicating dysplasia. There's variability, as you can see here, with eradicating metaplasia, which is all Barrett's. So in the UK registry, which is Graham Hadley's it's only 62% for getting to CRIM. And certainly our first run at the cryoballoon ablation has a very decent elimination of metaplasia. This is the hybrid APC preliminary results that they presented at this meeting. It's pretty decent, 92%. But a lot of them, again, you can see 90% of them had prior EMR. So you're actually resecting a lot of these Barrett's already. And then finally, stricture rates are pretty decent and comparable. And what we'll have to see eventually is comparative randomized control trials. Question? Yeah, so the question is, in non-dysplastic Barrett's, as long segment, do we use it? So certainly there are studies out there. In phase 1, the non-dysplastic RFA. It actually works very well without dysplasia. The current society guidelines and the current evidence does not support routine ablation of non-dysplastic Barrett's. In the gastro paper, which was, I forget what date that was, it was actually detailing the subsets of subgroups that might potentially be considered for non-dysplastic ablation. I personally, in my practice, and many people I know in the business, treat patients with family history of esophageal cancer and Barrett's. That's one indication, particularly a young patient who is a white male, who is long Barrett's esophagus. They have risk factors, obviously, for progression. And I have a long discussion with them about risk-benefit ratios. And so risk-benefit ratios are 5% overall adverse events, bleeding. You could even notch it up for, don't even include pain, but strictures, etc. Compared to someone without dysplasia, not even with family history, with no risk factors, then that risk-benefit ratio doesn't make sense because the progression rate in that kind of patient is much lower than the side effect profile. So it's about 1% or less, in the middle term. So those are the kinds of discussions you should have with your patients. Certainly, there are people who are comfortable with after that discussion doing it, moving ahead. But you want to tell your patients, because this is something that they need to understand. Once you get ablation, this does not cure you. You need to tell them that. And this is why I'm putting up these slides to end with, is that the remission rates are such that there is a remission over the first 2 years. And by year 3, you can see that people have recurrences. In fact, there was a Barrett session this morning I went to, did a very nice job of doing a meta-analysis systematic review that basically said that at year 2, when you reached CRIM, after reaching CRIM, your risk for recurrent Barrett's, this is metaplasia, no dysplasia, is about 7%. And at year 3, 4, 5, it doubles to 14%. So the number you should tell your patients, even if I've successfully treated you, and this is RFA, with RFA and you've done negative biopsies, you still have a risk of at least 14% to get Barrett's recurrence. So 1, they cannot be discharged from your practice. 2, they have to undergo regular surveillance. And that regular surveillance is dictated by what their grade was. So essentially, it happens in the first 2 years. You have to be very careful, even though there's neosquamous. Turn on your digital imaging, NBI or iScan, whatever. Look carefully. They're typically very small islands of mucosa. 75% of recurrences are in the hot zone, which is close to or at the GE junction. So always biopsy, always look at the GE junction after ablation. Those are where the recurrences are. And it's interesting with RFA that happens because when we do RFA 360, you always ablate the junction. And you bring them back, you ablate the junction again. You bring them back, you ablate the junction again. So these recurrences are happening despite treating the junction every single time. So again, why that is. So again, what is recommended based on the societies is that it's actually a quality indicator for you in your practice to know that you survey them the way that when they started, they came with low-grade dysplasia twice a year, and then annually thereafter, they came with high-grade dysplasia every 3 months for the first year, twice in the second year, and then annually. So if you're in the ablation business, please bring back your patients for surveillance because they may recur with dysplasia, and extremely rarely, about 1 or 2%, will they recur with cancer. All right? So if your patients go into the business of being ablated, even though they have non-dysplastic Barrett's, tell them they are not cured. So this is the biggest challenge we have in Barrett's after ablation is why is it that these recurrences are occurring? And in fact, one of the, just last thought before I end, one of the main thoughts is that potentially part of it is incomplete control of reflux. Sri Kamanduri and their had a retrospective study where they compared the recurrences in patients who had Nissen or some fundoplication aggressively for their GERD treatment after ablation, and the recurrences were much less compared to those who did not. That doesn't mean we're going to go out and do fundoplication in all these patients, but it implies at least there's this mechanism for why these patients recur. Right, so I think I'm out of time. Any other questions? Okay, the question is, what are the complications of cryo-balloon ablation? Yeah, so pain is minimal. We give them like kind of just overnight full liquids, the next day soft, and then regular. So the diet modification is very minimal. The pain is related to how long the Barrett's is and how much you ablated. So if I've ablated the full 10 centimeters of Barrett's, I tell them you have about a 1 in 4 chance that you'll have pain post-procedure that might require fentanyl or Tylenol. That pain will go away quickly, and the next day you have mild to none. But we do not prescribe narcotics routinely. We don't give Lowry solutions. All the stuff we do with RFA, we don't need to do that. We're dealing with a stricture rate that's about, in our paper, it was about 9.8%. In those 4 patients, I realized that actually 2 of them did not need a dilation, because you remember that the injury takes sometimes at least 2 weeks, sometimes 3 weeks. So you have to tell the patient that if they start having trouble with slowness of food, etc., that's inflammatory. Almost all of them, if you bring them in the first month, will have inflammation that's resolving, it's going to go away, and they don't need a dilation. They just to downgrade their diet, don't eat the big, hot dog and the whatever, and then downgrade it. When they downgrade and they follow that diet modification, they will not need dilation. So that's part of learning how this works compared to any other ablative device. Any other question, colleagues?
Long treatment Barrett, do you treat all in one session, or is it
So the question is treatment of long Barrett's in one session for any ablation technique, or? For cryo, yeah. So in this trial, what we published, we treated the entire length, and we had patients as long as 14 centimeters. We had in our IRB a maximum number of ablations just because we didn't know what it would be, of 24. So when we maxed out at 24, we stopped. It was unusual to have to do that many in a patient. But in those patients, I already tell them, okay, you're going to get some pain. They usually get some fentanyl and Tylenol after, but they tolerate it very well. But typically, you want to get all the Barrett's treated in the first session. By the time they come back the second session, you should have at least an 80% reduction. Ablation response, and that's becoming an industry standard throughout, all the ablative areas. Okay, so the question is, how does the balloon inflate? Do you have to have a certain volume, or yeah? So it's basically already programmed in the controller. That it reaches a certain inflation pressure. I think it's 3.2, forget. And there's actually, for safety, maximum pressure that it will allow before the valves open, and it will then vent. But it will maintain the pressure so you can see through the balloon. That's just what we call a pre-puff. And then you can see where you're targeting, and then you can direct it. The balloon pressure does not increase, even if you do 6, 8, whatever ablations, because the pressure is controlled by the controller. It will vent it to keep that pressure stable, so it does not keep increasing and bust open. So that's a very good safety measure in this design. So again, I don't work for the company, that's just the research. If you want to pass by their booth and just play with it, it's kind of neat. I'm sorry. The folds, yes, a very important part. So it's compliant. It's really compliant so that when you puff, yes, doctor. I don't know if you saw in the video, but it conforms to the shape, even if it's an S-shaped esophagus, which is a problem sometimes with the Halo 360 balloon. It conforms very well, and so you're able to most typically have good contact throughout the areas you're treating. There's some tips and tricks if you're treating near the junction where there's big hernias, there might be air pockets, but there's ways you can get rid of them. But contact is the most important factor in applying this cryogen dose to the mucosa. Right, yes, last one? Perforation rate, 0. Yeah, no perforation.
Spray. No, when I want to spray.
APC, they had one. I heard today in the plenary session, they had 1 perforation.
So you're
I think
dying.
it was treated endoscopically.
Position.
Yeah, the APC is hard because even, you know, I've done it. It's hard to really guess what the endpoint is, and you feel actually very, and I'm not intimidated, but when you keep burning and burning, and it's actually going to go through the muscle, you know, you don't really know how deep that burn goes, and that's where I think it's a fine line between how deep you can go with this high energy flight. But again, the studies are being done by expert people, and I think we have to see what they show. All right, I want to say thank you for staying awake and attending, and good luck to everybody.